My name is George Kovalevsky. I'm a reproductive endocrinology and infertility specialist at the Delaware Institute for Reproductive Medicine.
And my name is Emelia Bachman, and I work with Dr. Kovalevsky and Dr. Russell at the Delaware Institute for Reproductive Medicine.
And today we want to take just a few minutes to talk about one of the most difficult diagnoses that we have to deal with, and that's recurrent pregnancy loss, recurrent miscarriages. Dealing with recurrent pregnancy loss is such a frustrating and painful experience, because not only is a patient going through the pregnancy loss and having that terrible thing happening to them, in addition, oftentimes they're completely lost as to why is this happening in the first place. And sometimes we're not able to give an answer, and that makes this such a frustrating and such a challenging problem.
Yeah, I agree. It is one of the hardest things that someone can go through, and we are here for you. We're here to support you, and we'd love to talk about how, when you come for evaluation, what are some of the things we may do to help you. So George, when do you recommend that someone come for evaluation for recurrent pregnancy loss?
Yeah, so that's a great point, is that previously we used to say that 3 pregnancy losses is how long you should wait before starting an evaluation for recurrent miscarriages. However, in the last decade, we learned that that's too long to wait. And these days, based on the best studies that have been done, it makes the most sense to start after 2 consecutive pregnancy losses.
Yeah, I agree. I typically also recommend to my patients, and that is our recommendation, to come after 2. But even patients who have 1 loss, who are scared and want some answers, we may not do the full workup for them, but they can always come to seek some help and some advice as well.
Yeah, so that, I guess, then leads to the next question, is that when we do see patients with recurrent pregnancy loss, what tests do you like to get?
Yeah, so I know I like to break it down into categories for patients to understand it. We like to look at genetic factors, anatomic factors, endocrine factors, immunological factors, and we do testing in all of these categories. Do you want to talk about one of them?
Of course. The anatomic part is where I like to start with conceptually. So if something wrong with the house where the baby is going to live, the uterus, and particularly the inside of the uterus, the uterine cavity, can be a very big issue for the pregnancy's outcome. So we want to get a very good look inside the uterus, make sure there's nothing like polyps, fibroids, scar tissue, leftover tissue from previous pregnancies, all these things that can impact a good implantation. And there are several different ways we can do that. My favorite way is to do an office hysteroscopy, which gives us the best visualization of the uterine cavity, where we can take a little tiny camera and slide it in through the cervix up into the uterus to take a good look.
Yeah, another test we can do is a saline sonogram, where we put a tiny catheter in and we inject saline with an ultrasound to look at the uterine cavity, as well as a hysterosalpingogram, where you can take an X-ray of the uterine cavity, or some people also do 3D ultrasound to take a look at the inside of the uterus as well.
Great. The second part of the workup that is very important is to check the chromosomes of both the mother and the father, or of the pregnancy, to see if there are any hidden abnormalities called balanced translocations that can increase greatly the risk of a miscarriage.
Another thing that I like to look at are the endocrine factors, where we can look at thyroid antibodies, screening for diabetes, a hormone called prolactin. These are all hormones we do like to check to make sure these are normal, as these can affect implantation or the normal progression of pregnancy.
Next thing comes to mind are antiphospholipid antibodies. So a family of antibodies that have been associated with recurrent pregnancy loss. There are several different ones. Particularly, we look at anticardiolipin, lupus anticoagulant, and beta-2 glycoprotein 1. Lots of tests for us to do that allow us to get an idea if there's something that we can identify that is causing this problem. When we do all of the tests, and we've just, we've mentioned the main ones, but there are many others that we consider depending on the individual situation. If we find something specific, then of course we fix that problem. But half the time when we do the tests, we don't find anything specific. So then we kind of have unexplained recurrent pregnancy loss. But even in these cases, there are many things that we can do to help. Emelia, what do you offer in these situations?
I agree. In many cases, we do not find an answer, which is really frustrating. But what's important to remember is that does not mean that you do not still have a good chance to have a healthy baby. And that's, I think, really important for patients to know. So some patients may go on to have a normal pregnancy. Sometimes we offer patients in vitro fertilization with pre-implantation genetic testing. If we think there may be a genetic problem that's causing this, either from one of the parents, or that the embryo itself is abnormal, then we can test the embryos prior to pregnancy. So patients would have to go through the IVF cycle where we take eggs out, take sperm, create embryos in the lab, and we can genetically test them. Now, unfortunately, nothing's perfect, but this testing is approximately 98% accurate, and we can at least say, hey, now we know we have a healthy embryo to go back in the uterus before pregnancy occurs. So while this does not eliminate miscarriage, it can greatly reduce the risk of miscarriage in many patients. So we can offer that. Again, we want to talk to you about all your options and see what's best for you. What might be good for one person may not be the right plan for another person, but that's why we're happy to see you to talk to you about these options. And I also think what's really important is that support during the early pregnancy, and we can offer you that. Whether you get pregnant on your own or we help you with some treatment, we can help you here and monitor the pregnancy hormone levels and do early ultrasounds in the first trimester so that you know what's happening, and we give you that support here because we think that's really important. And so we are honored to see you and to help you and evaluate you fully and support you through this and take care of you through the first trimester and help you transition to your OBGYN.
And that's a very important point because we do have data to suggest that even just doing that, just that simple support and reassurance with follow-ups, ultrasounds, and that reassurance in itself, perhaps by reducing the amount of anxiety and stress, can help improve the outcome of the pregnancy and reduce the risk of miscarriage. So that's definitely a very big part of what we can do to help our patients going through recurrent pregnancy loss.
Agreed. So we're honored to see you at DIRM, the Delaware Institute for Reproductive Medicine. You can make an appointment with Dr. Kovalevsky, Dr. Russell, or myself if you would like to talk about these things. We would be happy to help you and walk you through this time.